Okay, so let's unpack this. When the unimaginable happens, you lose someone you love, it's just, it's an emotional earthquake, utterly devastating. And when that loss, that tragedy, is connected with medical care, it's completely natural to want answers. You instinctively want to know what happened, why it happened.
Absolutely. It's a fundamental human need, that search for understanding in the face of loss.
But what happens when that natural, understandable grief starts to morph into something else? Something that maybe, ironically, could actually cloud the path to real accountability, especially for families just drowning in pain, desperate to make sense of it all.
And that's where things get tricky, right? Because what's fascinating here is how often the immense complexities of medicine, and law for that matter, get sort of flattened out, oversimplified in the public conversation, especially when emotions are understandably running incredibly high.
Yeah. You've got families caught in this horrible pain, often totally overwhelmed by dense medical jargon, legal terms they've never heard.
Right. And they're driven to find meaning, to find answers, and sometimes, almost inevitably, to find someone to blame. It feels like the only way to cope.
So today we're going to explore why not every single tragic medical outcome automatically means a doctor or nurse failed. And really crucially, what that distinction means for how we as a society should think about genuine accountability.
That's a vital distinction. Because if we don't make it, we risk chasing shadows instead of substance.
Absolutely. So this deep dive is for you, our listener, especially if you've ever felt lost in that maze of medical and legal language, or if you're part of a family searching for some clarity beyond that initial shock and overwhelming grief. Our mission today is really to shed light on a critical, often misunderstood area, medical outcomes, these allegations of malpractice, and specifically the nuances surrounding Florida statute section 768.218.
Ah, yes, that particular statute. It's garnered a lot of attention, hasn't it?
It really has, because it significantly limits who can claim certain types of damages, specifically non-economic damages, things like pain and suffering when an adult dies due to alleged medical negligence, if they don't leave behind a spouse or minor children.
Which can leave some families, often adult children or parents of the deceased, with this immense, unbearable grief. But, legally speaking, no avenue to seek compensation for that specific kind of loss,
Yeah.
emotional loss.
Exactly. So we're going to try and dissect what really constitutes malpractice versus other kinds of medical outcomes. And we'll explore why a pretty significant advocacy movement, one focused almost entirely on repealing this statute, might actually be missing a crucial piece of the bigger picture.
The pursuit of true professional accountability, perhaps, beyond just the civil lawsuit aspect.
Precisely. This is about clarity, trying to understand all the angles, not about judging anyone's pain. It's about helping you, the listener, become truly well-informed on a really complex and emotional topic. Okay, let's start with something raw. That emotional truth. The immeasurable toll of losing someone close. It just naturally pushes grieving families to seek answers. That impulse is absolutely understandable. It's human.
Completely. You want to know why? You need to understand.
But the sources we've looked at for this deep dive, they highlight what they see as a kind of dangerous line, a line that some, maybe not all, but some in the movement to repeal this Florida statute, section 768.218, seem to have crossed.
And what line is that specifically?
It's the line moving from seeking understanding, which is totally valid, to assigning blame, often very quickly, and then from assigning blame privately to making public accusations.
Ah, and that's where the problem can really start to undermine the goal of actual justice, isn't it?
Exactly. When allegations start getting treated as if they're already proven facts, and when raw, understandable grief is presented almost as if it's evidence itself, well, that's not really justice anymore.
No, it becomes more like presumption masquerading as certainty, as the source material puts it. The emotional weight is so heavy, so overwhelming, it can unfortunately overshadow the absolute need for factual rigor, for careful legal and medical analysis.
Especially for folks who, through no fault of their own, don't have that specialized training in medicine or law. They're hearing everything through this filter of shock and grief, and sometimes the need for someone to be at fault becomes just overwhelming.
Then it becomes the narrative that makes sense of the senseless.
Right. And the hard truth, for anyone listening, is that not every poor outcome in medicine, even a fatal one, is the direct result of negligence. It's just not that simple.
Absolutely not. Not every bad result means a doctor or a healthcare provider failed in their duty.
To equate the two, bad outcome equals negligence, is really to fundamentally misunderstand how incredibly complex clinical practice actually is. You're dealing with the inherent unpredictability of human bodies, of disease processes.
And the incredibly high legal standard required to actually prove negligence in a court of law. It's a common misconception, I think, especially when emotions are so intense and the personal stakes are obviously astronomical.
So let's talk about that standard. You mentioned it's high.
It is, and arguably it needs to be. To successfully win a medical malpractice case, a plaintiff,
Hmm.
the person bringing the lawsuit has to prove 4 specific legal elements. It's not enough just to feel wronged.
Okay, what are they? Can you break them down?
Sure. Think of it maybe like steps you have to climb. First, you have to establish duty. The healthcare provider owed the patient a professional duty of care. That's usually straightforward doctor-patient relationship exists.
Okay, duty. Got it.
Second, breach. This is the core of it. You have to prove the provider failed to meet the accepted standard of care. That means showing what a reasonably competent provider in the same field would have done under similar circumstances, and that this provider fell below that standard.
Right, so not just any mistake, but one that a competent peer wouldn't have made.
Exactly. Third, causation. This is crucial. You have to prove that the providers breached their failure to meet the standard of care directly caused the patient's harm or death. It can't just be that a mistake happened and the patient had a bad outcome. The mistake has to be the direct cause.
That sounds like it could be really hard to prove, linking the specific action or inaction to the outcome.
It often is, especially in medically complex cases. And fourth, damages. You have to show that the harm resulted in actual compensable losses. These could be economic, like medical bills and lost wages, or non-economic, like pain, suffering, loss of companionship.
Duty, breach, causation, damages.
Meeting that whole standard, proving all 4 elements, is a significant challenge. It absolutely requires specific expert testimony from other medical professionals, admissible evidence presented in a compelling way.
And a narrative that truly convinces a jury that the provider's actions, or maybe their inaction, fell below that accepted standard.
Precisely. And let's be really clear here. The opposition in these cases is typically formidable. You're usually up against powerful insurance companies with deep pockets and very experienced defense attorneys who specialize in these cases. It's an uphill battle for many families, make no mistake.
Yet, despite that high bar, among some of the most vocal advocates for repealing this Florida law, subsection 8, there seems to be this, well, this troubling assumption
What's the assumption?
that if only that specific part of the statute were repealed, winning in court would be almost automatic. Like, just open the courthouse doors and justice in their favor will inevitably follow.
Ah, yes. That's where we often see a significant gap in understanding the whole process. Many of these individuals, and they're incredibly well-intentioned, driven by just profound personal loss.
Of course.
But they often lack formal medical training or hands-on clinical experience or even a basic legal education. They argue, understandably, from a place of deep emotion, intense grief, and often suspicion.
And those feelings are absolutely valid, utterly valid on a personal level.
Undeniably.
Yeah.
But those feelings alone, no matter how powerful, don't constitute legal or medical merit in a court of law. That understandable desire to blame someone, anyone, can sometimes unfortunately obscure the path to finding actual, verifiable proof that meets the legal standard.
To put it kind of bluntly, speculation just isn't evidence, right?
Mm.
An accusation, even one born from the deepest pain, doesn't magically become true just because it's repeated often or maybe shouted very loudly online.
Correct. And we've actually seen situations where these public accusations, driven by grief and conviction, can veer dangerously close to defamation, tarnishing professional reputations based on belief rather than established fact.
Which is kind of ironic, isn't it? It represents an absence of accountability within the advocacy itself, potentially undermining the very cause of justice they seek to advance. If you're demanding accountability from others, your own claims really need to be grounded in fact, not just raw emotion or suspicion.
It's a difficult balance, and it leads us to a really critical point of clarification about what repeal actually means.
Okay, what's that?
Repealing subsection 8 is not a verdict. It's not a judgment. It's not even a guarantee that you'll get your day in court for many types of outcomes.
So what is it then, legally speaking?
It's simply the restoration of standing for a specific type of damage claim in certain cases. Standing just means the legal right to ask a court, or potentially a jury, to evaluate the evidence. It opens the door to potentially make that specific claim for non-economic damages.
It opens the door, but it doesn't guarantee what you'll find on the other side, or even if you can get through it.
Exactly. Many advocates, sadly, seem to misunderstand fundamental legal principles. Things like the strict rules of evidence, what's admissible and what isn't, the immense burden of proof that still rests entirely on the plaintiff, the often prohibitive cost of pursuing litigation, especially expert witness fees.
And all the potential legal defenses the other side will undoubtedly raise.
Absolutely. Some don't even seem to grasp a basic concept in medicine, that two perfectly competent, reasonable doctors can look at the same complex patient and legitimately disagree on the best course of treatment. Neither one is necessarily negligent just because they chose different paths. Medicine isn't always black and white. There's often a lot of gray area.
So repeal is really just crossing the threshold into what is often a very, very long, frequently uncertain, and incredibly demanding legal battle.
No, precisely. The courtroom isn't designed for theories or emotional appeals alone. It's fundamentally a crucible for proof, hard evidence, expert testimony.
And taking on that burden is something very few individuals, especially those without legal expertise and grappling with grief, are truly prepared for.
It's a monumental task.
So here's where it gets really interesting and maybe a bit challenging. We're not in any way dismissing the profound pain these families feel. Not at all. But we are calling for precision in how we talk about this.
Yes, precision is key.
For you, the listener, understanding these crucial distinctions between grief and evidence, between a bad outcome and actual negligence, between standing and a verdict is absolutely key if you want to be a truly informed advocate or even just understand the debate.
Because to genuinely seek accountability, you have to be clear about what you're actually asking for and what the legal and medical systems can realistically deliver, which often goes far beyond just assigning blame to feel better.
Okay, so to really get our heads around what we mean or should mean when we talk about malpractice, it's incredibly helpful to break down adverse medical outcomes into distinct categories.
Why is that so important? Why not just lump everything bad under malpractice? Because that creates confusion and prevents clarity. Lumping everything together, honest mistakes, system failures, unavoidable events, actual negligence under that single loaded term malpractice does everyone a disservice. It prevents us from understanding what actually happened and what the appropriate response should be.
So these distinctions aren't just academic wordplay.
Not at all. They matter profoundly in law, obviously, but also in medicine for learning and improvement, and definitely in shaping sensible public policy.
Yeah.
It allows us to move beyond that understandable, but sometimes unhelpful impulse to just blame someone and get towards a more accurate picture of the event.
Okay, where should we start? What's the first category?
Let's start with human error. This is probably the most common type of issue. It refers to an unintentional action, or maybe a decision, that stems from our basic human cognitive limitations. Things like lapses in attention, momentary memory failures, misperceptions, or simple communication breakdowns.
So like normal human fallibility, stuff that happens to everyone in every field.
Exactly. It's a natural part of human behavior, especially in really complex high-pressure systems like healthcare, where people are making critical decisions, often very quickly, with incomplete information.
Okay, so the crucial point here is that human error, just by itself, is not automatically negligence.
That's absolutely critical to understand. An honest slip-up doesn't immediately equal legal liability. Human error only really becomes legally significant if that specific error should have been anticipated and prevented.
Prevented how?
Either by a reasonable professional acting carefully, or, more often discussed these days, by robust system safeguards. This is the whole idea behind systems-based safety in healthcare.
Right, the idea that people will inevitably make mistakes, so the system needs backups, checks and balances to catch them.
Precisely. Things like barcode scanning for medications to prevent mix-ups, surgical checklists and timeouts to prevent wrong-side surgery, mandatory double checks for high-risk drugs. It's about building in redundancy to protect patients from inevitable human fallibility.
Okay, so within human error, are there different types?
Yes, generally we talk about a few subtypes. There are slips and lapses. These are basically failures in executing an intended action correctly.
Like what?
A slip is when you intend to do the right thing, but you accidentally do the wrong thing. Like you mean to click on patient A's record in the electronic system, but your mouse slips and you click patient B's. Or you intend to grab one medication vial, but pick up the lookalike vial next to it.
Okay, an execution error. What's a lapse?
A lapse is more of a memory failure. You forget a critical step in a sequence, like maybe you're following a protocol, but you omit one crucial step because you were distracted or just had a momentary blank.
Got it. Slips and lapses are about doing the action wrong. What else?
Then there are mistakes.
Yeah.
These are different. They're failures in the planning or judgment stage before you even act. The intention itself was flawed.
Yeah.
Well, mistakes can be rule-based. That's where you apply the wrong rule or guideline to a situation. For instance, maybe a doctor assumes an elderly patient's chest pain is just indigestion. Because of an unconscious age bias, they applied the wrong mental rule instead of properly considering a potential heart attack.
Okay, applying the wrong rule. What's the other type of mistake?
Knowledge-based mistakes. These happen when the person simply lacks the necessary understanding or knowledge to make the right plan in the first place. Maybe they misdiagnose a very rare condition because they've never encountered it before and don't recognize the pattern.
Right, lack of knowledge for that specific situation.
And finally, a big one, communication errors. Pretty self-explanatory. Misinterpreting a verbal order shouted across a busy ER, confusing drugs with similar sounding names during a phone report, unclear handwriting on a chart leading to a wrong dose. Very common sources of error.
Okay, examples always help. Can you give us a real-world feel for these?
Sure, let's take the slip example. Imagine a busy lab. A phlebotomist draws blood from 2 patients back to back. They get momentarily distracted by an urgent page, and they accidentally put patient A's label on patient B's blood tube.
Oops.
Right. As a result, patient B gets an incorrect diagnosis, maybe anemia, and receives unnecessary treatment like iron infusions. That's a classic slip.
Is it negligence?
Is it? Not inherently, unless the hospital lacked a standard expected verification protocol, like maybe barcode scanning wristbands against tubes. That should have caught that error. The error itself is human. The system's failure to prevent or catch it is where the legal question might arise.
Okay. What about a lapse?
A nurse is administering medications. They misread the label on a vial. Maybe they see 5 milligrams instead of 0.5 milligrams because the print is small or the lighting is poor. The patient gets 10 times the intended dose. That's a perception lapse, a failure in execution. Again, it depends. Was it a reasonably foreseeable error given the labeling? Did the nurse bypass required safety checks, like having another nurse verify the dose for that specific drug? Negligence requires showing that a reasonably competent nurse wouldn't have made that mistake or that standard safety systems were ignored.
What about a more complex one, like wrong site surgery? That sounds more serious than a slip.
It absolutely is, and it often involves multiple human errors contributing. Maybe the surgical team marks the wrong limb, perhaps the preoperative timeout, that final safety check where everyone confirms the patient, procedure, and site is rushed or done poorly. Then the surgeon proceeds to operate on the incorrect knee or arm.
That seems clearly negligent.
It often is considered negligence, sometimes gross negligence, because it's seen as a never event, something so preventable with proper procedures that it should simply never happen. It usually points to a systemic failure of human error prevention, multiple people made errors, or failed to follow critical safety protocols. It could certainly rise to negligence if established safety systems were ignored, bypassed, or perhaps were fundamentally inadequate.
So the key takeaway for human error is?
Human error itself is inevitable because we're human, but preventable harm resulting from that error is not inevitable. The legal system tries, sometimes imperfectly, to distinguish between honest, isolated errors that occurred despite reasonable safeguards and those errors that happened because necessary safeguards were missing, inadequate, or simply ignored.
And connecting this back to that Florida statute, Section 768.2118.
In the specific cases covered by that statute, families are denied the very opportunity to even investigate if a human error crossed that critical line into actionable negligence causing a death. The door to inquiry, to finding out if a proper system could have prevented the tragedy, is slammed shut for them before they can even start asking questions.
Okay, so Category 1 was human error, often about individual slips or lapses. What's next?
Next is medical mistake. This is a somewhat broader category, definitely encompasses human errors, but it also explicitly includes things like system failures that might not be easily attributable to just one person's cognitive slip-up.
So it's a bigger umbrella.
You can think of it that way, yes.
Yeah.
It refers to really any unintended act, either doing something wrong, an act of commission, or failing to do something right, an act of omission, that happens during the planning or the delivery of healthcare. It deviates from what was intended or what was appropriate care.
And it goes beyond just individual cognitive issues.
Right. Medical mistakes can stem from a much wider range of problems. Things like communication breakdowns between different doctors or shifts, maybe technical malfunctions with medical equipment, workflow problems in a busy clinic or hospital, poor staffing levels, or even fundamental organizational issues like flawed policies or inadequate training programs.
But like human error, not all medical mistakes lead to harm.
Correct. And crucially, even if they do cause harm, not all medical mistakes meet that high legal threshold for negligence. Many mistakes happen, are caught, and corrected with no harm done. Others might cause minor harm but still fall short of being a breach of the standard of care.
What are some subtypes here? How do we break down medical mistake?
We can think about different types. There are diagnostic errors, things like a misdiagnosis, a wrong diagnosis, or a significantly delayed diagnosis. There are treatment errors, mistakes made during an operation, procedure, or test, or in administering a drug or therapy.
Okay, diagnosis and treatment. What else?
Preventive errors, failures to provide necessary prophylactic treatment or adequate monitoring or follow-up care that could have prevented a problem down the line. Communication failures, as we mentioned, poor handoffs, missed critical lab results, and system failures where the error is really rooted in the way the hospital or clinic is organized, staffed, or equipped.
Examples always help make these clearer. Can you give one for a diagnostic mistake?
Sure, a classic tragic example. A patient comes into the emergency room complaining of jaw pain and shortness of breath. The attending physician, maybe they're rushed, maybe the symptoms seem atypical, attributes it to anxiety. They don't order an EKG or cardiac enzyme tests. The patient is discharged. Hours later, at home, they suffer a massive heart attack.
That's a diagnostic mistake, clearly. But is it negligence?
That's the question for the legal system. For it to be actionable negligence, a jury, guided by expert testimony, would have to decide if a reasonably careful physician facing the same symptoms and circumstances would have acted differently. Would they have ordered those tests? Was attributing it to anxiety below the accepted standard of care in that situation? It's a critical judgment call.
What about a treatment mistake?
A common one involves medication, lookalikes, or sound-alikes. Say a nurse accidentally administers morphine instead of hydromorphone because the vials look very similar, a known issue with drug packaging. The patient gets significantly oversedated, but luckily recovers fully.
What's the analysis there?
It's clearly a treatment mistake. It might involve human error in perception, but it also points potentially to a system design flaw, the confusing packaging. Was it negligence? Again, it depends. Did the hospital have required safety checks for these drugs, like barcode scanning or mandatory independent double checks that were bypassed? If standard expected safeguards were missing or ignored, this mistake could become actionable negligence, especially if harm resulted.
And a communication mistake example.
Imagine a critical lab value, say, a dangerously high potassium level that can cause fatal heart rhythms, is reported by the lab over the phone to a nurse on a busy hospital ward. But somehow, that result never gets properly documented in the chart. Or perhaps it's documented, but never verbally communicated to the physician responsible for the patient.
And the consequence.
The patient develops a cardiac arrhythmia overnight and dies. This is clearly a communication-related medical mistake. Negligence would likely hinge on whether the hospital had clear, established protocols for handling and communicating critical lab values, and whether those protocols were actually followed. If known safety practices weren't implemented or weren't adhered to, that communication mistake can absolutely cross the line into negligence.
So for medical mistakes, the key legal question boils down to,
Was the mistake reasonably preventable under the circumstances, considering the available knowledge and systems? And did that specific mistake directly cause harm to the patient?
and relating this category back to Florida statute, section 768.218.
That statute, by barring wrongful death claims based on non-economic damages for certain families, like adult children of a deceased parent, prevents them from even initiating the legal process to investigate these questions. Even if a blatant medical mistake, maybe a communication failure or a diagnostic error, directly led to their loved one's death, the law says they can't sue for the pain and suffering aspect.
So the system doesn't even allow an inquiry into whether the mistake was just an unfortunate, harmless event or perhaps an excusable one given the circumstances, or if it actually constituted legally actionable negligence.
Exactly. For those specific families, the investigation is foreclosed by the statute before it can even begin. It leaves them not only grieving, but potentially with completely unanswered questions about whether preventable errors occurred, and with no legal recourse for their profound emotional suffering.
Okay, we've covered human error and the broader category of medical mistake. Now we get to the one everyone thinks of when they hear malpractice.
Right. Medical negligence. This is the big one, legally speaking. This is specifically the failure of a healthcare provider, a doctor, nurse, hospital, etc., to exercise the degree of care and skill that a reasonably competent provider in the same specialty would have used under similar circumstances.
And crucially,
And that failure directly results in injury or death to the patient. This isn't just an error or a mistake in passing. This is a clear breach of the legal duty of care owed by the provider to the patient. It's when a medical professional's conduct falls definitively below an accepted professional standard.
this is where those mistakes we talked about cross that line into legal culpability.
Precisely. And as we discussed earlier, to successfully prove a medical negligence claim in court, the plaintiff must establish all four of those elements we outlined: duty, breach, causation, and damages.
What characterizes negligence? What makes it different from just an error?
Usually, negligence involves elements like foreseeability. A reasonable provider should have foreseen that their action or inaction could lead to harm. Preventability, the harm could likely have been avoided if the provider had met the standard of care. And a clear departure from standard practice evidence showing that the provider did something or failed to do something that competent peers would not have done or would have done, respectively.
And it can be something they did or something they failed to do.
Absolutely. Negligence can be an act of commission doing something wrong, like prescribing a contraindicated medication. Or it can be an act of omission, failing to do something necessary, like failing to diagnose a condition despite clear symptoms, or failing to monitor a patient appropriately.
Let's get some concrete examples of clear negligence.
Okay, textbook example. A patient's medical record prominently displays, maybe even in red letters, a severe allergy to penicillin. The physician, perhaps they're rushed, perhaps they just don't check the allergy list thoroughly, prescribes penicillin anyway.
Oh,
The patient suffers a severe, life-threatening anaphylactic reaction. That's almost certainly medical negligence. The allergy was known, documented, easily verifiable. The standard of care absolutely requires checking allergies before prescribing. The failure to do so demonstrates a lack of reasonable diligence.
that seems clear-cut. Another one.
How about a surgical instrument, like a sponge or a clamp, being left inside a patient's body cavity after surgery? This is often referred to as gross negligence, and it's definitely considered a never event.
Why never event?
Because with proper surgical counts, protocols, and checklists, which are the standard of care, this should simply never happen. Leaving a foreign object inside a patient is a fundamental, undeniable breach of surgical protocol.
Okay. What about an example of negligence through omission failing to act?
Imagine a patient recovering from surgery under anesthesia. Hospital policy and standard nursing practice require the post-anesthesia care unit, PCU nurse, to check the patient's vital signs, especially respiratory rate and oxygen saturation, very frequently, say, every 15 minutes initially. The nurse gets overwhelmed with other patients or gets distracted and fails to check on this patient for over an hour.
And the outcome?
During that time, the patient develops respiratory depression from the anesthesia, their oxygen levels drop critically, and they suffer irreversible brain damage due to lack of oxygen. If the standard requires monitoring every 15 minutes and it wasn't done, and that failure directly led to the brain damage, that's a negligent omission.
Even if the nurse was genuinely overworked, does that matter legally?
Being overworked might explain why the lapse occurred, but it generally doesn't excuse the breach of the standard of care owed to that specific patient. Well, a hospital might bear some responsibility for understaffing, but the failure to monitor according to established standards can still be deemed negligent.
So the critical legal distinction between negligence and just an honest error or mistake hinges on.
It hinges on whether the provider's conduct, what they did or didn't do, fell below the objective professional standard of care. Remember, an honest error can still be considered negligence if a court finds that a reasonably competent provider would not have made that same mistake under the same circumstances.
It's not about whether they intended to cause harm.
No, intent is usually irrelevant in negligence cases, unless it's gross negligence or recklessness.
Yeah.
It's about the objective effect of their failure to adhere to the established professional standards expected of them. It's about what a competent professional should have done, regardless of intent.
In this category, medical negligence brings us right back to the core injustice perceived by critics of Florida statute, section 768.218.
Exactly. Because even in cases where there is clear, undeniable medical negligence, perhaps reckless conduct, a blatant disregard for safety protocol that directly causes the death of a patient,
If that patient doesn't happen to leave behind a surviving spouse or minor child,
then, under this Florida law, no claim for non-economic damages, Pain, suffering, loss of companionship, mental anguish can be brought by other surviving family members, like adult children or the parents of an adult child.
So the law in these specific tragic circumstances forecloses not only potential compensation for that immense emotional suffering.
But it also forecloses the very opportunity to present the evidence of that clear negligence to a jury in the context of a wrongful death claim, seeking those damages. It essentially says that for a certain category of people, their emotional suffering due to a negligent death doesn't warrant legal recognition or the chance for accountability in that specific way.
Which feels fundamentally unfair to many families. It suggests some lives, or rather the emotional loss associated with their deaths, are valued less by the legal system.
That's certainly the argument made by opponents of the statute. It prevents a jury from even hearing the case related to those damages, regardless of how clear the negligence might be.
Okay, we've talked about errors, mistakes, and clear negligence. But surely sometimes bad things happen in medicine even when everyone does everything right.
Absolutely. And that brings us to our fourth category, unavoidable outcomes. These are sometimes called non-negligent harms or simply bad outcomes. This category is critical, but often gets overlooked in the emotional aftermath of a tragedy, especially in that understandable search for someone to blame.
So what defines an unavoidable outcome?
It refers to a negative, sometimes fatal result that occurs despite appropriate medical care being provided. It's a situation where no individual provider acted outside the accepted standard of care, no preventable error, either human or system-based, occurred, and the harm arose from circumstances genuinely beyond anyone's control or beyond the reasonable capacity of the medical system at that moment.
So the duty of care existed, care was provided, maybe even excellent care.
Right. But ultimately, no breach of that duty is found. The care might have been entirely appropriate, timely, and skillfully delivered, but the outcome was still poor due to factors like the inherent limitations of current medical science, critical timing issues, overwhelming severity of the illness or injury, or perhaps unavoidable external constraints.
It's tragic, devastating for the family, but legally and medically, it's not attributed to fault or negligence.
Precisely. For an outcome to truly fall into this category, several criteria generally need to be met. All established protocols and standards of care should have been followed. No identifiable error, human or system, that could have been reasonably prevented should have occurred. And crucially, no other feasible medical intervention, given the circumstances and available knowledge, could likely have changed the ultimate outcome.
The harm then results from things like the limits of medicine, unforeseen biological variables, or maybe just overwhelming circumstances.
Exactly. Resource constraints, rapid disease progression, unforeseeable complications, catastrophic events.
You mentioned a true story earlier that fits here, the rural neurosurgeon case.
Yes, that's a perfect, albeit heartbreaking illustration. Remember, 2 rural hospitals sharing a single on-call neurosurgeon. A critical patient arrives at Hospital A from a bad car crash, needing immediate, complex brain surgery. The surgeon starts the life-saving operation.
And while he's deep in that procedure,
Another, equally critical patient arrives at Hospital B, also needing urgent neurosurgical intervention. The surgeon physically cannot be in 2 places at once. He cannot abandon the first patient mid-surgery. There's no backup neurosurgeon available due to the acknowledged realities of rural healthcare staffing. Tragically, the second patient dies before the surgeon can finish and get there.
and the family sued.
Understandably, yes.
Yeah.
They argue the hospital system was negligent for not having adequate coverage. But the court ultimately dismissed the case. It found no negligence on the part of the surgeon. He was acting appropriately. And the hospital was found to be compliant with accepted staffing standards for that type of rural facility.
So it was deemed unavoidable.
Yes, a tragic outcome directly resulting from severe, recognized resource limitations in that specific context. Heartbreaking, but not legally negligent.
What are some other examples of unavoidable outcomes, things listeners might relate to?
Unfortunately, they're not uncommon. Think about a young, healthy adult who goes to an urgent care with just a mild, non-specific headache. No real red flags, nothing to suggest imminent danger. An hour later, they collapse and die suddenly from a ruptured brain aneurysm that likely existed but was completely asymptomatic until that catastrophic moment.
Could a doctor have caught that?
Maybe,
Yeah.
maybe not. If the initial symptoms were truly subtle and nonspecific, even the most diligent clinician might not detect such a rapid, unpredictable event in time. There's no error, no mistake in judgment necessarily, just devastatingly bad timing and the limits of diagnostic capability for unheralded events.
What about chronic illness?
Right. Consider a patient with very advanced late-stage cancer. They're receiving excellent palliative care focused on comfort. They suddenly develop a massive pulmonary embolism, a blood clot in the lungs, and die. Maybe giving them strong blood thinners, anticoagulants, wasn't an option because they also had a high risk of fetal bleeding due to their cancer.
So the clot was a known risk, but preventing it carried its own unacceptable risks.
Exactly. It was a medically anticipated complication of their underlying disease, and the treatment limitations were justified. It wasn't neglect. It was the natural, albeit tragic progression of an incurable illness under complex circumstances.
Or even external events.
Absolutely. Imagine a major natural disaster, like a hurricane or earthquake. A patient reliant on kidney dialysis can't get to their treatment center because roads are impassable, power's out, the center is damaged, or emergency transport can't reach them. They suffer complications or die as a result.
Is the healthcare system liable there?
Generally, no, not if the system is functioning at its limits during a crisis, and providers are doing the best they can under impossible conditions. Liability doesn't usually attach when outcomes are dictated by overwhelming external forces, rather than failures in care delivery itself.
This category seems really important philosophically, too.
It is. It affirms a crucial point. Medicine is powerful, but it's not omnipotent. And the legal system shouldn't penalize dedicated caregivers for the inherent limits of science, biology, or reality itself. It's vital to recognize that not all deaths are due to someone's fault, and not all suffering is attributable to neglect. Sometimes tragedy strikes despite our best efforts.
And how does Florida Statute Section 768.21 interact with this category? It seems like these cases wouldn't result in liability anyway.
That's true. They likely wouldn't result in a finding of liability. But the statute's impact here is more subtle, yet still damaging, according to critics. By preemptively denying certain families the right to even bring a claim for non-economic damages, the law prevents them from having their day in court, from having the evidence formally reviewed, and from potentially getting a legal determination that the outcome was, in fact, unavoidable and not due to negligence.
So it denies them that closure, that official validation that everything possible was done.
Exactly. It can leave them forever wondering, forever suspecting negligence, because the system didn't allow them the chance to have a jury distinguish between negligence, an error, or simply unavoidable tragic fate. It assumes, in effect, that for certain lives lost, the inquiry itself isn't even worth undertaking for those specific damages.
Okay, this next category sounds intriguing. Justified deviations. What does that mean? It sounds almost contradictory.
It does, doesn't it? But it speaks to a really critical, often misunderstood reality of high-stakes medicine. Sometimes, in true life-or-death emergencies, rigidly adhering to the standard protocol, to the rule book, would actually guarantee a bad outcome, likely death.
So a doctor might have to break the rules to save a life.
Precisely. Competent, experienced physicians, and sometimes other clinicians like nurses or paramedics, may need to intentionally deviate from established protocols or standard operating procedures because the unique, urgent circumstances demand it. These aren't acts of negligence. They are considered justified deviations made in good faith to avert a catastrophe.
You mentioned you had a personal experience with this.
Yes, vividly. Decades ago, when I was a critical care nurse, I was caring for a patient fresh out of major heart surgery, coronary artery bypass grafting, CABG. He was in the ICU, seemed stable, and then suddenly his blood pressure just plummeted.
Who crashed?
It's an immediate, terrifying sign. The most likely cause is that one of the new bypass grafts has failed or clotted off. The heart isn't getting blood. It means death is imminent, literally minutes away, if blood flow isn't restored instantly.
What did you do?
Called a code blue, standard procedure. The surgeon happened to be nearby in the ICU, heard the call, came running. He took one look at the monitors, instantly suspected graft failure, and without a moment's hesitation, he started opening the patient's sternum, cracking his chest open right there on the ICU bed.
In the ICU, not in a sterile operating room.
No time. Zero time. Transporting him back to the OR would have taken far too long. He would have been dead. So the surgeon acted immediately. No sterile gloves, no mask, no proper surgical drapes, no skin prep with antiseptic. None of the standard sterile techniques you'd always use for surgery.
That sounds like a massive breach of protocol.
On paper, absolutely. A textbook violation of countless hospital policies and fundamental surgical standards of care. But he knew instinctively that dealing with a potential post-operative infection later was a secondary concern. The immediate overriding priority was restoring blood flow to the heart right now.
And did it work?
He found the failed graft, repaired it right there, and the patient survived. He lived. It's fascinating that family never even considered suing the doctor who technically blew standard of care out of the water. Why? Because in that specific, desperate life-or-death context, his deviation was the highest standard of care possible. It required incredible courage, decisive action, and brilliant improvisation, not just rote compliance with a checklist.
Wow, that's a powerful story. Are there other examples like that?
Definitely. Think about an obstetrician facing a situation where a baby's heart rate suddenly disappears on the monitor during labor. The operating room isn't immediately ready, maybe it's occupied. The OB might make the call to perform an emergency C-section right there, the labor and delivery room, or even the ER without full sterile prep.
Again, breaking the rules.
Yes. No proper surgical scrub, maybe no anesthesiologist perfectly positioned yet, no ideal sterile field. But the justification is crystal clear. Waiting even a few more minutes to follow perfect protocol would result in the baby's death or severe brain damage. It's a direct choice between protocol and survival.
What about a nurse acting independently?
Sure. An experienced ICU nurse recognizes the signs of imminent cardiac arrest due to hyperkalemia, dangerously high potassium. They see the characteristic changes on the heart monitor. They know the immediate treatment is intravenous calcium. The physician isn't right there at the bedside yet. The nurse grabs calcium chloride from the craft cart and pushes it immediately before getting a verbal or written order.
Which violates policy, right? Nurses usually need an order.
Absolutely violates standard policy.
Right.
But delaying those few seconds or minutes to wait for the physician to arrive and give the order could literally be fatal. The nurse's justified deviation, based on their expert assessment of an immediate life threat, stabilizes the patient.
And even outside the hospital.
Imagine a paramedic in a very remote area, maybe a wilderness rescue. They encounter a patient who is choking, completely unable to breathe, turning blue. Standard airway equipment isn't working or isn't available. As a last resort, the paramedic uses a ballpoint pen barrel to perform a makeshift cricothyrotomy, creating an emergency airway directly into the trachea.
Definitely not standard procedure.
Not even close. Not FDA-approved equipment, probably outside their official scope of practice protocols. But the justification is stark. The patient is minutes from death from asphyxiation, and there is absolutely no other alternative available at that moment. It's an improvised, life-saving deviation.
Is there legal backing for these kinds of actions?
Yes, there are established legal and ethical frameworks that recognize these situations. Things like the concept of implied consent in emergencies, assuming the patient would consent if able. Good Samaritan statutes, in many places, offer legal protection to those who render emergency aid in good faith. And most importantly, the emergency exception to the standard of care, sometimes called the emergency doctrine.
What does that doctrine say?
It basically says that the standard of care must be evaluated differently in a sudden, unforeseen emergency. The question isn't, what would a provider do in an ideal, controlled setting? But rather, what was reasonable and necessary for this provider to do, given the immediate life-threatening crisis they were facing? It allows for context.
So how does this relate to the Florida statute section 768.218 debate?
Critically, because that statute, by barring certain claims outright, doesn't allow for this essential context to ever be presented or evaluated by a jury in those cases. It prevents the family from bringing the case forward for non-economic damages, meaning the system never gets to formally distinguish between a negligent act and a justified life-saving deviation.
So the doctor who heroically broke the rules to save a life is never formally recognized or vindicated in court because no case related to those damages can be filed by that family.
Correct. And conversely, a provider who perhaps negligently deviated from protocol causing harm might also escape that specific form of accountability if the deceased patient falls into the category covered by subsection 8.
Without a jury able to hear the evidence, weigh the circumstances, and apply the emergency doctrine when appropriate, there's no formal distinction made. Only silence.
Exactly. The system, in these specific instances covered by the statute, fails to differentiate. It provides no forum for acknowledging either extraordinary skill under pressure or condemning clear wrongdoing, at least not through that specific type of claim by those families.
Okay, we have one more category to unpack. Reasonable clinical judgment. This sounds like something that comes up a lot in medical discussions.
It does, and it's another one that's frequently misunderstood, particularly, the sources suggest, by advocacy groups or laypersons who may lack deep medical or legal insight. It's a crucial concept for protecting doctors while ensuring accountability.
So what is it? Define reasonable clinical judgment for us.
It refers to the physician's decision-making process when they have to choose among multiple acceptable medical options. all of which fall within the recognized standard of care for that particular condition or situation.
Multiple acceptable options. That seems key.
It is absolutely key. Modern medicine often isn't a single pathway. For many conditions, there might be 2 or 3 valid diagnostic tests to start with, several different medications that are considered appropriate first-line treatments, or different surgical versus non-surgical strategies, all supported by evidence and considered acceptable practice by the medical community.
So the doctor has to choose one path among several valid ones.
Exactly. And the doctrine of reasonable clinical judgment protects a physician from liability if they make a choice among these accepted options in good faith, based on the medical knowledge available at the time, and the choice itself isn't considered irresponsible or reckless, even if the outcome isn't perfect, or another choice, in hindsight, might have turned out better.
Why is this protection important?
Because medicine isn't about having a crystal ball. Physicians shouldn't be held liable simply for not being omniscient or for not being able to perfectly predict how an individual patient will respond to a standard treatment. It allows doctors to practice without the constant fear of lawsuits, simply because a reasonable standard choice didn't lead to the desired result in this specific case.
Can you give us an example?
Sure. Let's say a patient presents with symptoms suggesting possible spinal cord impingement. The physician decides to order a CT scan first, perhaps because it's faster to obtain in their facility and can rule out certain urgent issues quickly. The CT scan comes back inconclusive or negative. Later, an MRI is ordered, which does show a significant disc herniation causing the impingement.
And the family might complain.
The family, understandably frustrated by the delay in diagnosis, might argue, you should have ordered the MRI first, would have shown the problem right away.
But is that negligence?
Probably not, under the reasonable clinical judgment doctrine. Both CT and MRI are accepted diagnostic tools for evaluating spinal issues. Choosing one over the other initially, based on factors like speed, availability, cost, or specific clinical suspicion, is generally considered within the physician's clinical discretion, as long as both are recognized options. Ordering the CT first wasn't outside the standard of care, even if the MRI ultimately provided the definitive answer.
Okay, another example, maybe involving medication.
Right. A doctor diagnoses a patient with a common heart arrhythmia and prescribes medication A, which is a standard, guideline-recommended beta blocker known to be effective for many patients with this condition. However, this particular patient has an unexpected adverse reaction and develops severe bradycardia, a very slow heart rate.
What might the argument be?
The family might research online and find that medication B, perhaps a different class of drug like a calcium channel blocker, is also used for this arrhythmia and might have had a lower risk of bradycardia in some studies. They argue the doctor should have chosen medication B.
Negligence again.
Likely not. If medication A is within the established treatment guidelines and is a common, accepted first-line therapy, the doctor's choice to use it reflects reasonable clinical judgment. The fact that an alternative existed, or that this patient had an unfortunate, known, but perhaps statistically uncommon side effect, doesn't automatically make the initial standard choice negligent. Adverse outcomes don't retroactively prove the initial judgment was unreasonable.
One more. Maybe conservative versus aggressive treatment.
Okay. A patient is diagnosed with diverticulitis, which is an inflammation in the colon. Depending on the severity and the patient's overall health, there are 2 main approaches: conservative management, antibiotics, bowel rest, pain control, or more aggressive management, immediate surgery. The physician assesses the patient, decides the case appears uncomplicated, and opts for conservative management initially.
But what if it doesn't work?
Unfortunately, the patient's condition worsens despite the antibiotics, and they end up needing emergency surgery a few days later. The family might then insist, you should have done surgery right away, this could have been prevented.
The doctor's defense.
Reasonable clinical judgment. Both conservative management and upfront surgery are valid. Accepted treatment pathways for diverticulitis, depending on the clinical picture. The physician weighed the risks and benefits of each approach. Surgery has significant risks too, and made a choice that was considered reasonable and within the standard of care at the time. The fact that the chosen path didn't succeed in this case doesn't mean the initial decision was negligent.
You mentioned this category is often misused or misunderstood by advocacy groups.
Yes, the source material suggests this is a common issue. Advocacy groups, perhaps fueled by grief and the desire for accountability, sometimes fall into the trap of hindsight bias. They argue, essentially, if a different decision might have saved the patient or led to a better outcome, then the decision that was made must have been negligent.
But that ignores the reality of medicine.
Completely. It ignores the fact that there are often multiple acceptable choices. that doctors aren't fortune tellers, and that the law requires reasonableness at the time the decision was made, not perfection judged with hindsight. It also ignores the fact that perfectly competent physicians often disagree amongst themselves about the single best approach for a complex patient. Clinical judgment is protected, legally and ethically, as long as it falls within that broad spectrum of accepted medical practice.
And the connection to Florida statute, section 768.214 line here.
Again, the statute eliminates the opportunity for those specific families covered by it to have a court formally assess whether the physician's decision truly represented a reasonable clinical judgment, or if it actually crossed the line into negligence, or perhaps was even a heroic justified deviation.
So families might be left suspecting the doctor just made a bad call, but they have no forum to get answers or have the decision evaluated against the standard of care.
Exactly. They may never get a detailed evidence-based explanation through the legal process. This lack of a forum can foster suspicion, resentment, and allow misinformation to spread because formal legal inquiry and explanation are barred for them regarding non-economic damages. The courtroom, with its structured process, rules of evidence, and reliance on expert testimony, is designed to be the proper venue to determine if care met the standard, if judgment was reasonable, and if the outcome was preventable due to negligence. Without that venue, speculation and unanswered questions can fester.
Okay, so we spent quite a bit of time really breaking down the complexities here. We've looked at human error, medical mistakes, actual negligence, those unavoidable tragedies, justified deviations, and reasonable clinical judgment. It's clearly not simple.
Not at all. It's a landscape full of nuance.
So what does all this mean for you, the listener, and maybe more broadly for the conversation around medical accountability in places like Florida? We've laid out this complex reality of medical outcomes. Now, let's kind of pivot and look at how some advocacy movements are approaching this whole issue and where the source material we reviewed suggests they might be, well, maybe missing the mark a bit, particularly regarding their stance on Florida Statute Section 768.218.
Yes, I think this is a really important part of the discussion. The source material strongly suggests that this intense, almost singular focus on a clean repeal or nothing stance regarding subsection 8 is precisely where some advocates have perhaps misdirected their energy or at least oversimplified the solution.
What do you mean by clean repeal or nothing?
It means they're focused almost exclusively on getting rid of that specific subsection of the law, often without considering other related reforms or potential compromises, and they seem to operate under the belief that this single-act repeal is the magic bullet, the panacea that will automatically fix everything related to medical accountability for the families affected.
But as we've just spent a lot of time discussing, that's not really accurate, is it?
No, it's not. As we clarified, repealing subsection 8 is not a verdict. It doesn't guarantee a win in court. It doesn't even guarantee you'll get to present your full case easily.
It's just about restoring standing, the right to ask for a certain type of damages.
Exactly. It's merely the restoration of the legal right for those specific families to ask a jury to evaluate their claim for non-economic damages like pain and suffering. It gets them potentially to the courthouse door for that specific claim, but it says nothing about whether they can actually prove their case once inside.
It's just the very first preliminary step on what we establish is often a very long, very uncertain, incredibly difficult, and frankly really expensive legal journey towards maybe getting a jury award.
A journey that, realistically, very few people, especially those grieving and without legal or medical backgrounds, are truly prepared to undertake. The passionate conviction and the understandable desire for justice are there, but the practical realities of litigation are often underestimated.
So, many of these well-meaning advocates, caught up in their grief and understandably wanting someone held accountable, might have convinced themselves that if this one specific legal barrier is removed, victory is assured, accountability automatically follows.
That seems to be the underlying, perhaps unstated, assumption driving some of the rhetoric. And it's a dangerous oversimplification, the source material argues. It can lead to false hope for families and potentially misdirects advocacy efforts away from other, perhaps more impactful, avenues for reform.
And this leads to another really crucial disconnect you mentioned earlier, one that needs highlighting.
Yes, it's the difference between monetary awards from a civil court and actual professional accountability.
Explain that distinction again. It seems vital.
Okay, even if a family does manage to navigate the entire legal gauntlet, they get past subsection 8 repeal, if it happens. They find lawyers, they gather evidence, they pay for experts, they endure depositions and trial, and they actually win a verdict from a jury. Let's say they get a substantial monetary award for damages, whether it's capped or uncapped.
Even after all that success in civil court.
That civil victory does not automatically trigger any professional discipline for the healthcare provider involved. Zero automatic consequence for their license or ability to practice.
Really? So the court says they were negligent and have to pay, but they can just go back to work the next day.
Essentially, yes. A civil court's job is to assign financial liability. Its primary purpose, in these cases, is to compensate the victim or their family for the losses suffered due to the negligence. It provides restitution. It does not, by itself, impact the provider's medical license, their hospital privileges, or their fundamental ability to continue practicing medicine.
Those things are handled separately.
Entirely separately.
Yeah.
Professional consequences like suspension, probation, mandatory retraining, or license revocation only happen if the case is also reviewed and acted upon by the relevant state regulatory body. In Florida, that would primarily be the Florida Department of Health, DOH, and its associated professional boards like the Board of Medicine or Board of Nursing.
And this is a point that seems significantly lost or downplayed in the current advocacy message focused solely on repeal.
Very much so, according to the analysis we reviewed. The source material makes a really sharp observation here, pointing out that advocates have often confused uncapped jury awards on non-economic damages with accountability.
How so?
They seem to equate getting a large financial settlement or verdict with achieving accountability. But at the same time, they often and understandably insist it's not about the money.
That does sound contradictory.
It is. The message becomes off, as the source puts it. If the ultimate stated goal is true accountability, which presumably means ensuring negligent providers face professional consequences and are prevented from harming other patients in the future, then focusing almost exclusively on the right to pursue monetary awards addresses only one part, arguably the less systemic part, of the problem.
It suggests a fundamental misunderstanding, maybe, of how the different pieces of the healthcare accountability system, the courts, and the regulatory agencies actually function and what their respective roles are.
Exactly. It's about where the advocacy efforts are aimed. Are they aimed purely at financial compensation for past harm, or are they also aimed at preventing future harm through robust professional oversight? The current focus seems heavily skewed towards the former, potentially neglecting the latter.
This really shines a light on what seems like a disjointed, maybe even fragmented system of accountability in Florida. You've got the civil courts doing one thing and the regulatory bodies doing another, and they don't seem to be perfectly aligned.
That's a very accurate description. They operate with different mandates, different goals, and critically, as we'll discuss, very different burdens of proof. Understanding this disconnect is absolutely key if you want to figure out where the real leverage points for systemic change might be.
Okay, so let's break down that distinction clearly. First, the civil court system, where a family might file a medical malpractice lawsuit. What's the standard of proof there again?
In civil court, for the plaintiff, the family, to win, they need to prove their case by a preponderance of the evidence.
Which means
It's the lowest legal standard of proof. It basically means they need to show that it's more likely than not. I think 51% or greater certainty that the four elements of malpractice, duty, breach, causation, damages, occurred as they claim.
and the main goal of the civil court in these cases is
Primarily, it's about compensation, making the victim whole, financially speaking, for their losses. That includes tangible economic losses like medical bills and lost income, but also those intangible non-economic losses like pain, suffering, emotional distress, loss of companionship, the very damages often at issue with subsection 8. It's about restitution for the harm done to that specific individual or family.
Okay, so that's the civil court. 51% certainty focused on compensation. Now, what about the other side? The Florida Department of Health, DOH, and the Agency for Healthcare Administration, AHCA.
Right. These are the state regulatory agencies. The DOH, through its various professional boards, like the Board of Medicine, Board of Nursing, is responsible for licensing healthcare professionals, investigating complaints against them, and imposing discipline when warranted. AHCA oversees healthcare facilities like hospitals and clinics.
And their standard of proof is different.
Significantly different. For the DOH to impose serious disciplinary action against a provider's license, things like suspension, restriction, or outright revocation, they generally need to prove the misconduct by clear and convincing evidence.
Clear and convincing. What does that translate to, roughly?
It's a much higher standard than preponderance. While there's no exact percentage, it's often thought of as requiring something closer to 75% certainty. It means the evidence must produce a firm belief or conviction in the mind of the fact finder, usually the professional board, that the allegations are true. It's a substantial burden.
Why the big difference? Why 51% for civil court and closer to 75% for licensed discipline?
There's a clear rationale behind it. stemming from the different objectives and consequences involved in each system.
Okay, explain that.
Well, think about the objectives first. Civil courts exist to resolve private disputes, primarily financial ones, between parties. The lower preponderance standard makes it somewhat more practical for individual victims, who often face challenges gathering evidence, to seek monetary redress for their private losses.
It balances the scales a bit for the victim.
Arguably, yes. The regulatory boards, on the other hand, have a different primary mandate, protecting the public's health and safety by ensuring licensed professionals maintain competence and ethical standards. But they also have a duty to protect licensees from potentially unfounded, career-destroying complaints, maybe politically motivated or retaliatory.
So the higher standard acts as a safeguard for the professional.
Exactly. That clear and convincing standard serves as a crucial procedural safeguard. It acts as a buffer, ensuring that the severe consequence of losing one's license and livelihood is only imposed when the evidence of wrongdoing is truly substantial and persuasive, not just marginally, more likely than not. Civil juries might also lack deep medical expertise, making the lower burden more practical there, whereas professional boards are composed of peers who evaluate the evidence with expert understanding.
And the severity of the outcome is different, too.
Vastly different. Civil penalties are usually monetary. While potentially large, money is, in theory, reversible or manageable through things like insurance, payment plans, or even bankruptcy. But license revocation, that's often permanent. It's the professional equivalent of capital punishment, an irreversible end to one's chosen career and livelihood. Such a severe outcome understandably demands a much higher degree of certainty before it's imposed.
What are the practical implications of this disjointed system with its two different standards?
The implications for justice, especially from the public's perspective, can be profound and frustrating. You can very easily have the exact scenario we alluded to earlier. A physician or hospital is found liable for negligence in civil court under the 51% preponderance standard. The family receives a monetary award.
But then,
the very same case, reviewed by the Department of Health or the Board of Medicine under the higher, clear and convincing standard, might result in no disciplinary action against the provider's license. The board might conclude that while negligence was perhaps more likely than not, the evidence doesn't meet that much higher threshold required for formal professional sanction.
which leads to that feeling of impunity you mentioned.
Exactly. It creates a public perception, often quite strong, that the system is broken. A doctor is found liable in court for harming a patient through negligence, yet they can continue practicing medicine without any apparent professional consequence. It feels like they got away with it, leading to immense frustration for the family and potentially eroding public trust.
But is that outcome, however frustrating, actually consistent with how the two systems are designed to work?
Paradoxically, yes. It aligns with each system's distinct mandate. The civil court fulfilled its function, compensating the victim. The regulatory board also fulfilled its function, applying its higher standard to determine if the evidence warranted the severe step of license discipline, focusing on ongoing risk to the public rather than just past error.
Are there any connecting points? Does a civil verdict ever influence the board?
There are some mitigating factors and potential connections. Boards can sometimes impose less severe non-punitive measures, like requiring additional education or practice monitoring, even if the high standard for formal discipline isn't met. And importantly, in Florida, there's a statute, Section 45636, that allows the Board of Medicine to take action based on repeated medical malpractice, which is usually defined as 3 or more civil judgments or settlements within a certain period.
So multiple civil losses can eventually trigger board action.
Yes, theoretically. But a single civil verdict, even a large one, often doesn't automatically equate to professional misconduct warranting license action under the board's independent review and higher evidentiary standard. The core reality remains. It's largely a two-track system, operating independently. So reflecting on this whole structure, this disjointed system, it really brings up a critical question, doesn't it? Especially for those deeply involved in advocacy around medical harm.
Which is?
If the message is truly, it's not just about the money, as advocates often and sincerely state, and if we now understand that simply repealing subsection 8 doesn't automatically guarantee professional accountability, even if a civil suit is successful, then what is the larger mission here? And perhaps more importantly, how can advocates refocus their efforts to achieve that broader goal more effectively?
That seems like the million-dollar question, right? The sources we looked at strongly suggest that the current advocacy movement, if it really wants to evolve its message, maybe enhance its credibility with lawmakers and achieve more systemic change, should probably take a hard look at this institutional gap we just outlined.
The gap between the civil courts and the regulatory bodies.
Exactly. Instead of pouring almost all their energy into solely achieving courtroom access for non-economic damages, which again primarily leads to potential financial awards, the suggestion is that reformers should perhaps be pressing the Florida legislature much harder to investigate why. Why do so many complaints filed directly with the Department of Health and AHCA alleging serious provider misconduct seem to result in no meaningful professional action? Where is the breakdown in that regulatory process?
That feels like a shift from focusing only on compensating past harm to actively trying to prevent future harm by strengthening professional oversight.
Precisely. This could mean advocating for very specific legislative reforms aimed squarely at professional accountability, not just civil liability reform.
Like what kind of reforms?
Well, possibilities mentioned include things like requiring mandatory automatic reviews by the DOH or the relevant board of all civil verdicts and perhaps significant malpractice settlements, ensuring that every instance where negligence is found or strongly suggested in the civil system actually gets a thorough look from the regulators.
So bridging that information gap between the two systems.
Yes, or perhaps more controversially, considering whether the evidentiary threshold, that clear and convincing standard, should be lowered for certain types of proven negligence or specific instances of discipline, where the wrongdoing is fairly clear but maybe doesn't quite reach that very high 75% certainty bar for full license revocation. Is the bar set too high in some cases?
That would be a significant policy debate.
Absolutely. Other ideas include pushing for much greater transparency in the regulatory complaint resolution process. Why are cases dismissed? What actions are taken? Letting the public and referring families have more insight. And maybe even creating automatic disciplinary triggers for the most egregious, undeniable violations, those never events we talked about, like leaving an instrument inside a patient. Should those automatically lead to some form of license action?
These are concrete proposals targeting the regulatory side, the professional accountability side.
Right. And it's really interesting to bring Governor DeSantis back into this briefly. Remember, he vetoed that bill, HB 6017, which aimed to repeal certain restrictions similar to subsection 8. And his veto message was very specific.
What did he say?
He pointed out precisely that the bill failed because it lacked two key things: comprehensive regulatory reform addressing the DOH and AHCA processes, and it lacked any kind of cap on non-economic damages.
So he basically laid out a roadmap.
In a way, yes. The source material argues he effectively gave the advocates the keys to potentially getting a repeal bill signed. He outlined what would make such legislation palatable: pairing the repeal or modification of the damages restriction with both some form of caps and meaningful reforms to the professional regulatory system.
But the advocacy movement hasn't really picked up on that regulatory reform piece.
Apparently not with the same vigor. The focus seems to have remained almost entirely fixated on achieving an uncapped, clean repeal of the damages restriction, while largely ignoring the governor's explicit call for parallel reforms aimed at strengthening the DOH and AHCA's ability to provide actual professional accountability.
Which, again, highlights that potential disconnect,
Mm-hmm.
claiming it's not about the money while fighting hardest over the uncapped monetary damages, and potentially missing an opportunity to also push for reforms that directly address preventing future harm by negligent providers.
Exactly. It suggests the message might be off, or at least not fully aligned with the stated goal of broader accountability. They seem to be hardlining on one specific aspect, perhaps at the expense of making progress on the larger systemic problem.
So the larger mission here, if we take a step back, isn't just about restoring a specific family's right to seek certain damages in court, although that's certainly an important element of compassion and individual justice.
What is the larger mission, then?
The larger mission, the source material contends, has to be about ensuring that negligent providers are prevented from harming others. And that absolutely critical public safety aspect remains largely unaddressed by an advocacy strategy focused solely on repealing subsection 8.
True justice, in this view, requires both things.
Yes, it requires both reasonable access to the courts for fair compensation when negligence causes harm and a robust, effective, transparent regulatory system that is capable of acting decisively when professional wrongdoing is proven, thereby protecting future patients. You need both sides of the coin.
This really calls for a different kind of advocacy, doesn't it? One grounded in maybe more precision, discipline, and perhaps humility.
I think that's fair. while repealing or reforming subsection 8 might well be a just and necessary step to restore a legal right that many feel was wrongly taken away. The force argues that pretending repeal is a magic wand, pretending every family would automatically win huge awards, or that repeal alone guarantees true professional accountability is simply naive optimism.
And potentially counterproductive?
Yes, potentially a disservice to the very cause they're fighting for, because it oversimplifies the problem and might alienate potential allies or policymakers who see the need for a more balanced, comprehensive approach.
So an approach that acknowledges the complexity that clearly distinguishes between unavoidable outcomes, honest errors, and actual negligence, and then uses that nuanced understanding to advocate for comprehensive systemic change. That approach might be more credible.
That's the argument. It positions the advocacy not just as an emotional appeal based on grief, though that's the valid starting point, but as a reasonable, evidence-based case for reforms that address both individual compensation and public safety through professional accountability.
If we connect this to the bigger picture, it really means moving beyond that simplistic, maybe politically easier, clean repeal or nothing stance.
Yes, it means digging deeper, understanding the systemic issues, particularly that institutional gap between civil court outcomes and regulatory actions. And then advocating for specific changes, maybe mandatory reviews, maybe adjusted evidence standards in some cases. Definitely more transparency changes that truly protect the public by holding negligent providers professionally accountable, not just making them or their insurers financially liable after the fact.
It's about looking at the whole ecosystem, recognizing the nuances, and focusing on reforms that promise lasting, meaningful improvements to patient safety and professional oversight.
A much heavier lift, perhaps, than just focusing on one statute, but potentially far more impactful in the long run.
Hashtag outro. Wow. Okay, so this deep dive has really taken us through some complex territory. Hopefully, for you, the listener, it's offered a clearer path to understanding the profound nuances surrounding medical outcomes.
Yeah, we've explored those 6 distinct categories, trying carefully to highlight the critical, often blurred differences between unavoidable tragedies, simple human errors, broader medical mistakes, and actual provable medical negligence.
It's definitely not a simple black and white world in medicine or law, and we've learned together that not every adverse outcome, no matter how devastating it feels, automatically means someone was legally at fault.
And we also shone a pretty bright light on that significant discrepancy, the differing burdens of proof between our civil courts, which primarily focus on providing financial restitution to individuals.
Right, that 51% likelihood standard.
And the professional regulatory boards, which operate under a much higher, clear, and convincing standard, aiming to ensure ongoing public safety and uphold professional standards, but sometimes failing to act, even when civil liability has been found.
That disparity really reveals the current limitations, the disjointedness in achieving truly comprehensive professional accountability. It's a gap that can leave families feeling justice wasn't fully served, even if they win a monetary award.
So the path forward, if we're talking about a more just system overall, seems clear from this analysis. It really has to involve both ensuring fair and reasonable access to the courts for compensation when negligence does occur.
And simultaneously building or reforming a truly robust, effective, and transparent regulatory system. One that can actually act decisively and consistently when professional wrongdoing is proven, regardless of the civil outcome, thereby helping to prevent future harm to other patients.
True accountability seems to demand serious attention to both sides of that coin, compensation and prevention.
It really does, and this raises a fundamental question, I think, for all of us as a society. How do we effectively balance these two vital needs?
How do we balance the moral and legal imperative to compensate those who have been genuinely harmed by negligence with the equally vital need to foster a healthcare system where providers feel able to make difficult, high-stakes decisions using reasonable clinical judgment without constant fear of litigation for less than perfect outcomes, and where accountability for true wrongdoing is both swift, certain, and transparent?
That's the tightrope, isn't it? For you, the learner, we hope this deep dive has offered a way to grasp these complexities, to see beyond the often simplistic headlines or the raw emotion of blame, and maybe to identify more clearly where real systemic change could actually make a difference.
The question for all of us, really, as we think about striving for a more just, more compassionate, and safer healthcare system is this.
In our pursuit of justice after a medical tragedy, are we absolutely clear on the kind of accountability we are truly fighting for? Is it just financial? Is it professional? Is it systemic improvement? And are the methods we're using, the reforms we're demanding, actually aligned with achieving that ultimate multifaceted goal?
A provocative thought to leave you with. Finding that balance is perhaps one of the most critical challenges facing healthcare policy today.